welcome to the deep dive. You wanted to get a solid handle on central retinal vein occlusion, CRVO, based on your notes, and that's exactly what we're going to do today.
Yeah, absolutely. Our aim is to make this info really clear, memorable, and genuinely helpful for you.
Great. So we're taking your notes on CRVO, exploring it step by step.
Exactly. From what it is right through to how it's managed. Think of it as, your personal guide to understanding this important eye condition.
Okay, let's start right at the beginning then. What exactly is central retinal vein occlusion?
Well, basically, CRVO is a blockage. It's in the main vein, the central one, that drains blood away from your retina.
And the retina is that light-sensitive bit at the back.
Precisely. Essential for vision. So when that main vein gets blocked, it's like think of a traffic jam. Blood can't flow out properly.
Right, a backup.
Exactly. And that leads to congestion, a lack of oxygen, which we call ischemia, and potentially, unfortunately, vision loss. It's actually a pretty common cause of sudden, painless vision loss. You see it more in older adults, but honestly, it can happen at any age.
You mentioned ischemia there, that lack of oxygen. That sounds like a key factor.
Oh, it really is. It puts major stress on the retinal cells, stops them working right.
And your notes mentioned two main types.
Yes, we classify CRVO by how severe the blood flow issue is. There's non-ischemic and ischemic.
Yeah.
And the ischemic type, that's the more serious one. It means there's a really significant reduction in blood supply to the retina.
Which means a worse outlook?
Unfortunately, yes. A much higher risk of severe vision loss and complications down the line.
Got it. So one's kind of milder, one's more severe based on that blood flow. What actually causes the blockage, though? The etiology.
Right, the underlying causes. Well, they can differ a bit between the two types. For non-ischemic CRVO, it's often something like mechanical compression, the vein gets squeezed,
right,
or maybe a blood clot, a thrombosis forms right inside the vein.
And the ischemic type.
That one, as we said, is linked to that severe lack of blood flow. But looking broadly, common factors for both include those blood clots, atherosclerosis, hardening of the arteries,
right,
inflammation of the blood vessels, which is vasculitis, or conditions that make blood thicker or more likely to clot, what we call hypercoagulable states.
So could be a physical block, could be the blood itself. Are there specific things that make someone more likely to get CRVO? Your notes had that mnemonic.
Ah, yes. That's a great way to remember the main risk factors. Age, pressure, sweetness, heart.
Okay, break that down.
So increasing age is definitely a big factor. Our vessels just aren't as flexible. Then pressure, high blood pressure, hypertension, puts a lot of strain on those delicate retinal vessels.
Makes sense.
Sweetness points towards diabetes. Diabetes can damage small blood vessels everywhere, including the eye.
Right.
And finally, heart problems, cardiovascular disease. Often involves issues with circulation and blood vessels generally.
Age, pressure, sweetness, heart. That's really helpful.
It is. And we should probably also mention glaucoma, that's increased pressure inside the eye, and also polycythaemia.
Polycythaemia.
Yeah, where you have too many red blood cells. It makes the blood thicker, more prone to clotting.
What good addition. So age, pressure, sweetness, heart, plus glaucoma and thick blood.
Got it.
Yeah. Now let's dig into what's actually happening inside the eye. The pathophysiology. You used the blocked pipe analogy earlier.
That blocked pipe idea is pretty spot on, actually. The blockage of that central retinal vein, that's step one.
Okay.
That stops the normal outflow of blood. So you get a backup, pressure increases in all those retinal veins upstream.
Right, the congestion.
Exactly. And that congestion, combined with the higher pressure, means the retina starts getting starved of oxygen. That's the ischemia we keep mentioning.
And if the retina isn't getting oxygen?
It can't function properly, which leads to vision loss. Now, the most common reason for the blockage is usually a thrombus, a blood clot forming right there.
Yeah.
But it could also be, say, disease in the vein wall itself or something pressing on the vein from outside.
Yeah.
And once you have that stagnant blood, the lack of oxygen, hypoxia, and then stuff starts leaking out of the vessels into the retina, extravasation, it creates this negative feedback loop.
Vicious cycle.
Pretty much. And remember VEGF.
Yes. Vascular endothelial growth factor. You mentioned it with the ischemic type.
Exactly. In ischemic CRVO, that severe oxygen shortage triggers the release of loads of VEGF.
And that's bad here.
Well, VEGF normally helps grow new blood vessels, which sounds good. But here, it causes these abnormal, fragile new vessels to grow on the retina, sometimes on the iris, too.
Fragile means they can break.
Precisely. They leak, they bleed easily, so you can get bleeding inside the eye, or even a really nasty type of glaucoma caused by these new vessels blocking drainage, neovascular glaucoma. The body's trying to fix it, but actually makes things worse.
Wow. So it really cascades after that initial blockage. Are there other contributing factors besides those main age, pressure, sweetness, heart risks?
Oh, definitely. Things like raised intraocular pressure, even if it's not full-blown glaucoma, inflammatory diseases throughout the body, increased blood viscosity for other reasons, and those thrombophilic disorders, the clotting problems we mentioned. It's also been linked sometimes to things like chronic kidney disease, even autoimmune diseases. It really shows how eye health is connected to overall systemic health.
It really does. Okay,
Yeah.
this gives a great picture of what CRVO is and why it happens. Now, how do doctors differentiate this? If someone comes in with vision loss, how do you know it's CRVO and not something else? The differential diagnosis.
That's a crucial step, yeah. Differential diagnosis. We have to consider other things that cause similar symptoms, like could it be a blockage in just one branch of the vein, that's branch retinal vein occlusion?
Oh, okay.
Smaller scale?
Exactly. Or could it be damage from diabetes, diabetic retinopathy?
That can look similar sometimes. We also think about a retinal artery occlusion blocking the inflow, not the outflow. Retinal detachment, where the retina actually lifts off the back of the eye. Or just macular edema, swelling in the center, maybe from another cause.
So how do you tell them apart?
A really thorough eye exam is key. The ophthalmologist looks for specific clues, like the pattern of the bleeding, how widespread it is. That helps distinguish central versus branch occlusion. The specific appearance of the optic nerve and macula. Lots of signs to piece together.
Like detective work in the eye. Got it. Now, how common is this? The epidemiology.
Yeah, the numbers. CRVO affects about 1 in every 1,000 people over 40.
Okay.
And like we said, it gets more common as you get older, and definitely seen more often in people with diabetes and high blood pressure.
So not incredibly rare,
Yeah.
and definitely linked to those common systemic issues. What about what someone actually experiences? The clinical presentation.
Right. What do you notice? The absolute hallmark sign is sudden, painless loss of vision in one eye. That's the big one.
Sudden and painless. Okay.
Then when the doctor looks in, they see those specific signs we mentioned. Bleeding in the retinal hemorrhages, swollen, kind of twisty-looking retinal veins, we call them, dilated and tortuous. Maybe white patches called cotton wool spots, which are signs of nerve fiber damage from lack of oxygen. Swelling in the macula, macular edema, sometimes swelling of the optic disc itself, especially early on.
Is it always dramatic vision loss?
Not always, actually, especially with the non-ischemic type. Some people might have really mild symptoms at first, maybe just a bit of blurriness or even nothing they notice immediately. It really depends how much the macula, the center of your vision, is affected.
Okay.
But typically it's one eye, painless blurring, sometimes distorted vision metamorphopsia where straight lines look wavy.
Oh, yeah.
And occasionally people lose a specific part of their visual field, often the top or bottom half, an altitudinal field defect. Visual acuity, how sharp the vision is, depends heavily on that macular involvement.
And you can see differences between the types when looking in.
Yes, definitely. When the doctor does fundoscopy, looking at the fundus, the back of the eye, they see those swollen veins and hemorrhages. In non-ischemic CRVO, maybe only a mild pupil reaction issue, lots of small dot and blot or flame-shaped hemorrhages, maybe some disc swelling.
And ischemic.
Ischemic CRVO usually means much worse vision loss from the start. A more obvious issue with the pupil's reaction to light and afferent pupillary defect, more dramatic optic disc swelling, and often that really striking blood and thunder appearance.
Blood and thunder.
Yeah, it means extensive, large hemorrhages all over the retina, plus more of those cotton wool spots. It looks quite dramatic.
That description certainly sticks. So if someone presents like this, what investigations are done to confirm it?
Well, that comprehensive eye exam is the absolute cornerstone, checking the vision, looking inside. But often, the key investigation is fluorescein angiography.
The dye test.
Exactly. Inject dye into an arm vein, take pictures as it flows through the retinal vessels. It shows blockages, leakage, areas of ischemia really clearly. It's often considered the gold standard for confirming CRVO and assessing how ischemic it is.
Okay. What else?
Optical coherence tomography, OCT, that's crucial too. It's like an ultrasound but uses light waves, gives amazing cross-section images of the retina, perfect for seeing macular edema, quantifying it, seeing structural changes.
Non-invasive too.
Totally non-invasive. And we'll measure the pressure inside the eye, the intraocular pressure. Then, because of those systemic links, we usually do other tests.
Like checking blood pressure.
Definitely. Blood pressure, blood sugar, cholesterol levels, maybe thyroid tests, a full blood count, ESR to check for inflammation.
Hmm.
Sometimes more specialized things like plasma protein electrophoresis and ECG for the heart, maybe tests for clotting disorders, a thrombophilia screen, especially if the patient is younger or there's no obvious cause.
Wow, quite a workup.
It can be. Depending on the picture, maybe C-reactive protein, ACE levels, autoantibodies, even a chest x-ray or homocysteine levels. In the eye clinic itself, we might repeat the pressure check and use OCT angiography, OCTA, which visualizes blood flow without dye.
Sounds very thorough, covering the eye and potential underlying causes. So once CRVO is diagnosed, what's the management plan? What can be done?
The main focus really is twofold. Manage any underlying health problems and prevent or treat the complications in the eye.
Okay, so tackling the risk factors.
Absolutely. Getting blood pressure under control. Optimizing blood sugar if there's diabetes. Managing cholesterol. These are crucial.
And for the eye itself, the swelling or new vessels.
Right. For macular edema, or that neovascularization, the main treatment now is often injections directly into the eye, intravitreal injections of anti-VEGF drugs.
The ones that block that VEGF factor.
Exactly. They help reduce the swelling and stop those leaky new vessels from growing, or even make them regress. They've really revolutionized treatment.
Are there other options? Laser.
Yes, laser photocoagulation can still be an option. It's often used more to treat the neovascularization in the periphery of the retina to prevent bleeding, or sometimes for stubborn macular edema, though anti-VEGF is usually first line for edema now.
And speed is important.
Critical. Anyone suspected of having CRVO needs an urgent referral to an ophthalmologist, ideally within 24 hours. We need to confirm the diagnosis, figure out if it's ischemic or non-ischemic, because that guides management and prognosis.
Right.
And if the eye pressure is high, that needs treating too. Plus, advising on modifiable risks, smoking cessation, diet, exercise. It's a team effort between ophthalmology and the GP to manage the eye and the overall cardiovascular risk.
What about things like HRT? I saw a note on that.
Yeah, historically, hormone replacement therapy was often advised against in women with a history of any vein occlusion. Now it's more nuanced, considered on an individual basis, weighing risks and benefits. And definitely, in younger patients who get CRVO, we look harder for underlying systemic causes.
Makes sense. A real multi-pronged approach. What about the longer term? What's the prognosis typically like?
The prognosis. It really varies quite a bit. The biggest factor is whether it's non-ischemic or ischemic, and how much of the retina, especially the macula, is affected.
Ischemic is generally worse, you said?
Generally, yes. Ischemic CRVO has a less favorable outcome and a higher risk of those complications we talked about. Early diagnosis, getting the right treatment quickly, and regular follow-up are all vital for the best possible prognosis.
Will vision recover fully?
Often, unfortunately, no. Many people end up with some permanent reduction in central vision, usually because of chronic macular edema. For non-ischemic CRVO, maybe less than 10% get back to completely normal vision. Most have some ongoing impairment. And worryingly, about a third of non-ischemic cases can actually progress and become ischemic within about 3 years.
Oh, wow. And for ischemic?
For ischemic CRVO, the outlook is often quite poor, sadly. Significant permanent vision loss is common. Maybe 90% end up with substantially impaired vision. There's a high risk, maybe 50% of developing new vessels on the iris within months, and a high chance of neovascularizations somewhere in the eye.
That sounds quite serious.
It is. The good news, perhaps, is that CRVO itself doesn't seem to increase overall mortality risk, but there is a definite risk of it happening in the other eye later on, so monitoring is key.
Right, ongoing vigilance. And finally, what are the main complications we need to be aware of?
Okay, the big ones to watch for are persistent macular edema, that swelling, retinal neovascularization, those bad new blood vessels.
Which can bleed.
Exactly, leading to vitreous hemorrhage, bleeding inside the main gel-filled cavity of the eye. Those vessels can also form scar tissue that pulls on the retina, causing a tractional retinal detachment.
Okay.
And then there's glaucoma, specifically neovascular glaucoma, if those new vessels grow on the iris and block fluid drainage, causing very high eye pressure and optic nerve damage.
So managing those is key.
Absolutely. Regular monitoring and treating these complications promptly if they arise is crucial to save whatever vision is possible. Neovascularization is more likely if there's a large area of ischemia. On the slightly brighter side, maybe about half of people overall might regain relatively good vision, say 612 or better. But again, over half can get macular edema, and maybe 1 in 5 develops retinal neovascularization. So it's a mixed bag.
That's a really thorough run-through of central retinal vein occlusion.
Yeah.
Just to quickly recap the absolutely key points for everyone listening. CRVO is that blockage in the main retinal vein. Think risk factors: age, pressure, sweetness, heart. It's vital to know if it's the milder, non-ischemic, or more severe ischemic type. Management is all about tackling underlying causes like blood pressure and diabetes, and treating eye complications like swelling and new vessels with things like anti-VEGF injections.
Spot on.
And the absolute main message: sudden, painless vision loss needs immediate medical attention. Don't wait.
Couldn't agree more. Time really is vision with conditions like this.
Definitely. And thinking about those strong links you mentioned, CRVO with hypertension, diabetes,
Yeah.
it really underscores how important it is for all of us to think about proactive steps for our general vascular health, doesn't it?
It absolutely does. Looking after your overall health is a massive part of protecting your sight. It's all interconnected.
Indeed. Well, for those of you revising this topic and others for your exams, do check out passthemsra.com. It's a brilliant resource.
Yeah, really useful.
And for more free learning materials, you can also head over to freemsra.com. Thanks so much for diving deep with us today.